Welcome back, everyone. Today we are diving into a pediatric classic. Picture this. You're in the grocery store and you see a parent give their toddler's arm a quick, sudden tug to keep them from knocking over a display of cereal boxes. Suddenly, the child stops using that arm. It's hanging there, slightly flexed, and they're refusing to even pick up a toy. Dr. Sarah, what are we looking at here?
That is the textbook presentation of radial head subluxation, more commonly known as nursemaid's elbow. It's one of the most frequent musculoskeletal injuries in children under 5. From an academic standpoint, we need to be very precise about the anatomy involved because it is a favorite for board examiners.
I love this topic because it's high drama for the parents, but a high satisfaction fix for the clinician. But let's get into the why. Dr. Sarah, why does a simple tug cause this much trouble in a kid, but if I pull on your arm, nothing happens?
It's all about the maturity of the radial head. In adults, the proximal end of the radius is shaped like a wide mushroom cap, which is firmly held against the ulna by the anular ligament. However, in young children, specifically between ages 1 and 4, the radial head is more cylindrical, almost like a straight peg. It hasn't fully developed that cap shape yet.
Right. It's like trying to keep a wedding ring on a finger that hasn't grown a knuckle yet. If you pull hard enough, that ring is sliding right off. In this case, the ring is the anular ligament. Dr. Sarah, hit us with the high-yield anatomy of that ligament.
Exactly. High-yield point number 1. The anular ligament is the primary structure involved. When sudden traction is applied to an extended pronated arm, the small radial head actually slips partially through the ligament. The ligament then becomes trapped between the radial head and the capitellum of the humerus. This is technically a subluxation, not a full dislocation.
And why does this matter clinically? Because when you see that child in the ER or your clinic, they look like they have a paralyzed arm. They aren't crying usually unless you try to move it, but they are protecting it. They keep it in a guarded position, elbow slightly bent and the forearm turned palm down or pronated.
That guarded position is key. On the boards, they will describe a child who refuses to supinate the arm. They'll also emphasize that there is no swelling, no redness, and no bruising. If you see significant swelling or deformity, your mind should immediately shift away from nursemaid's elbow toward a supracondylar fracture.
Great point. If it's puffy, it's likely a fracture. But if the history fits, that sudden jerk or pull, and the physical exam is clean other than the refusal to move, you've got your diagnosis. Now, Dr. Sarah, boards love to ask about the next best step. Do we need an x-ray for this?
This is a classic trap. If the history is classic for nursemaid's elbow, the next best step is not an x-ray. It's a clinical diagnosis. In fact, the subluxation is often so subtle that the x-ray would look completely normal anyway. The next best step is actually the reduction maneuver itself.
And this is where you become the hero of the day. If you are the family's doctor of choice, you can fix this in seconds. There are 2 main ways to reduce it. The traditional way is the supination flexion technique. You put your thumb over the radial head, supinate the forearm so the palm is up, and then flex the elbow all the way up so the hand touches the shoulder. You'll often feel a satisfying click under your thumb.
Research actually suggests a second method might be even more effective on the first try, the hyperpronation technique. You hold the child's elbow at 90 degrees and quickly move the forearm into extreme pronation, turning the palm down further. Studies show hyperpronation has a higher first attempt success rate, which is definitely something to keep in mind for clinical practice and updated exams.
I've tried both, and honestly, that pop or click is the best sound in medicine. But why does this matter clinically after the click? Because you have to wait. The child won't immediately start doing cartwheels. The ligament was pinched, so it's a bit sore.
True. Typically, we ask the parents to take the child back to the waiting room for 10 or 15 minutes. If the reduction worked, you'll see the child reaching for a lollipop or a toy with that arm shortly after. If they are still not using it after 20 minutes, then you might consider that x-ray to look for a subtle fracture.
What about recurrence, Sarah? Once that ring has slipped off the finger once, is it easier for it to happen again?
Absolutely. Parents need to be counseled that until the radial head grows and becomes more bulbous around age 5 or 6, this can happen again. The most important clinical advice is to tell parents and caregivers to lift children by their armpits or the upper arm, never by the hands or wrists.
It's such a simple anatomical glitch with a dramatic clinical payoff. To recap for the listeners, it's a subluxation where the radial head slips through the anular ligament. It happens because the radial head is still cylindrical in toddlers.
And for the boards, look for the pull history, the pronated/flexed arm, and the lack of swelling. Remember, the anular ligament is the culprit. Reduction via supination flexion or hyperpronation is the treatment, and no x-ray is needed for a classic presentation.
Perfect summary. It's the ultimate why does this matter topic because you can literally fix a paralyzed child with a flick of the wrist. Thanks for joining us today.